go to the surgical aspect. Request Dr. Prafulla to take us through the difficulties, challenges in doing a phaco in these patients. Dr. Prafulla has been a part of making this program, and in fact, they've got a good session made.
Thank you, sir, for that kind introduction. So I'll be dealing with surgical challenges that one may encounter while doing cataract surgery in a patient of keratoconus or other form of corneal ectasia. The major challenge in such cases is biometry and IOL selection, which Dr. Mantu has covered so nicely. During surgery, there are three main issues. First is visualization. Why? Because the cornea is irregular. At times there could be scar because of healed hydrops or subepithelial scarring. So visualization is a big problem. The most important part that I feel is depth perception. It gives you false depth. So that is a bit tricky while doing your posterior capsular polishing. The second part is wound creation. So you are dealing with a cornea which is inherently weak. So the location of an incision can impact the final post-op outcome. It can induce some astigmatism, unwanted astigmatism. The wound may not seal, and all this problem may be there with clear corneal incision that we are accustomed with. Phacoemulsification is not different from routine cataract surgery, but one problem is the interchamber volume is too high, too big. So I will show you in video what really happens when we are doing phacoemulsification. This was a case of keratoconus. As I just highlighted, clear corneal incision has so many issues. So it's better to go for limbal or corneoscleral, or even few surgeons they do scleral tunnel and then do phacoemulsification. So limbal incision, this is what I prefer. And routine steps like injecting air, trypan glue should be there, because why? The visibility part can be taken care of by using trypan glue. It improves the contrast and it will help you in rhexis, and also while doing cortical aspiration, if your phaco or IA probe is near the cone area, then that rhexis margin may not be that apparent, so that will help you in that. The second part is whether to use cystitome or capsular rhexis forceps. If you notice here, the moment my instrument is going beneath the cone, there is a distortion. So it's better to use capsular rhexis forceps. Why? Because you can follow the arc and complete your rhexis. With cystitome, there may be little bit difficulty because needle is fine structure, and beneath that cone there may be distortion and you may not appreciate the depth appropriately. Rest of the steps are like a routine cataract surgery, but do all these steps little bit gently. And this is the problem that I was telling about. The moment you start your irrigation on, the pupil dilates, and as if the interchamber depth has significantly increased, that you will get that feeling. So to avoid that, you can lower your bottle height and you can select the IOP which is on lower side. This is another issues with keratoconus patients, because you tend to go a little bit posterior while making incision. You can have conjunctival ballooning while operating, doing phacoemulsification. So you can make few nicks with your MBR knife or conjunctival scissor to get rid of that. Another problem is, since the volume is big, the nuclear pieces they tend to run off from your phaco probe. So what you can do is you can inject viscoelastic and achieve a little bit pseudo cushion and then complete your phacoemulsification. Nuclear grade is usually on softer side in these cases because these patients usually present early, so that phacoemulsification part is not difficult. IOL incision is similar to your routine cases, but yes, you can get some hidden pieces lying here and there. So when you are doing irrigation aspiration at the end of the procedure, so do it little bit longer compared to your routine cases, so that all these hidden pieces are taken care of. The second scenario is when there is some opacity. Here it was a case of keratoconus along with pellucid marginal corneal degeneration with a healed hydrops, but fortunately the scar is of the visual axis, so that was not a big problem. But remember, when you are doing corneal or clear corneal or limbal incision in a scarred cornea, the amount of astigmatism that you may induce much larger compared to a routine cornea. So you should avoid the scarring area. However, if it is inevitable, always try to go perpendicular to the location of the scar if you are making incision near that. Then rhexis, all this thing, as I showed you in the previous video, it's like always strain the capsule and use capsular rhexis forceps if possible. So the problem with visualization, you can take care of by these three. This is just a summary of these two videos. Use viscoelastic to coat the corneal surface. Why? Because viscoelastic will prevent your epithelial dehydration during the procedure, and also they will give you some little magnification of intraocular contents. Trypan blue you should always use, it will help you in rhexis as well as during irrigation aspiration. RGP, there is a this OE et al, they have published this series where they have used RGP lens during cataract surgery, and if you notice this picture, this is a picture with contact lens. You can see the intercapsule is clearly apparent. Here there is some distortion of the intercapsule. So if you use a RGP lens during surgery, that can improve your visibility. Corneal incision, you should always avoid corneal incision, always go for a limbal or corneoscleral incision, avoid scarring areas, and always try to put a suture if you are little bit doubtful about the self-sealing nature of the corneal incision. And if your patient is not happy with suture, you can put a drop of fibrin glue at the end of the procedure. This is a nomogram. Dr. Manpreet has already covered this quite nicely, how to choose. So ensure that the patient is having a stable keratoconus. And one other important thing is a history of good preoperative corrected distance visual acuity. So I'll just give you one example. This is what I have encountered in my setup. So one kid was referred to me for cataract surgery under general anesthesia. Why? Because the surgeon, they didn't have general GA setup for cataract surgery. So when I see the patient, there was a little bit cortical cataract. Yes, the patient had keratoconus. The cataract was not that significant. But if you see the patient carefully, he has all the characteristic features of Lawrence-Moon-Biddle syndrome. There is truncal obesity, there is short and stubby fingers. Of course, on pentagram there was keratoconus, but if you see the left eye, the cortical, where the cortical cataract, there is complete pallor of the optic disc. So loss of vision in that kid was not because of keratoconus with cataract, but it was due to the optic atrophy, associated optic atrophy. So whenever you are planning cataract surgery in patients with keratoconus, always ensure that the patient had at some point of time good corrected distance visual acuity. And this is a new IOL that I just came across while reviewing the literature. The Northy et al, they have described this IOL used in keratoconus patients. It's a small aperture IOL where there is a ring of pigmentation from 1.23 mm to 3.23 mm. The hypothesis is that it will prevent all the peripherally scattered light to enter into and reach the retina. It will only allow the centrally focused rays to reach your retina. And the initial result they are claiming good, but I think we need more studies on this. With this, I would like to conclude here. I would like to acknowledge Professor Namta Sharma and Dr. Priyadarshini for helping me in this presentation. Thank you very much.